So now you should start seeing people.
Hello, everybody. I hope everybody's joining us. We're going to also um, we're going to start our Young ESPGHAN webinar, and I'm very happy to moderate this session with the topic of IBD, fertility, and pregnancy, which is going to be lectured by Dr. Avni. I'm going to talk about her in a second. And before we start our webinar, I would like to also share to everybody what are our activities in the Young ESPGHAN committee. Our mission is promote high quality research and training, to organize activities for young ESPGHAN members, for all the trainees, and represent the interests of young ESPGHAN members within the council of the society. We think these are our main objects that we are always encouraging. And what type of educational events are we working on? If you went to the annual meeting, you remember the mentorship program. You will see, and also I encourage you to apply, because the mentorship program, is to meet and receive pastoral support from more than one senior, or maybe one senior ESPGHAN member. And we started this and since 2017. And in this annual meeting in 2025, we have 12 pairs, mentoring style workshops, and also in-person meetings, also with the face-to-face in Helsinki. A Young ESPGHAN Day, if you went to our sessions, we go through we went through the coding research with systematic reviews, meta-analysis, and peer review essentials with a workshop program. And what we are continually doing with the reviewer program, encouraging new reviewers to the GPGN with GPGN. We also, besides the scientific sessions and all the learning, we also have some relaxing activities, such as the immersive painting that we had. It was a very nice also activity in which we can also make contacts and meet new people, which is also very, very important. We also had in this annual meeting our new Young ESPGHAN session, which was the expert dialogues, navigating clinical cases, in which we have some experts and young in the session, helping us to discuss different cases which were submitted by all the participants. We also have our meeting with the presidents, and and we can talk with them. We can also give them some perspectives from our view with the young people, which is very important. We have also an educational programs we are upcoming, and I hope I encourage you to check also the courses and see not just the Young ESPGHAN, but also the ESPGHAN programs that are very important for you to get a better training. The Research Academy, we have also a new, and this year is a very important activity, because I think in this one you can also learn not just to make contact, but also you learn how to research, how to make new programs, and learn all clinical translational research, statistics, training, trial designs, and it's very, 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 very important. These are our committee. We are, as you see, a very, very powerful group, and also a very workful group. As you know, Anne-Marie is our chair, Vangelis is our secretary, Petra is our treasurer, Francesca, our very communication manager, Pinar, international affairs, Mara, who is working with the webinars. Me, I'm working with the reviewer program. Giovanna Poto is in the JIC representative. Harwin the nutrition, and Beno with the hepatology commitment. I encourage you, if you have some other questions and if you want to also contact us, we are very open to help you. This is, if you are not a member, please join us, because we have all these new activities and also very benefits that you can see also in the website. How you become? Please join in the website, and so you can see. We have also our app in Android and ESPGHAN, and you can see here in the Instagram also that we are very active. What are the next webinars we have? It's in November, the reviewer session, the second part, and December, the Christmas quiz. And for the next year, designing, interpreting clinical trials, which are very also important. And now I would like to introduce Dr. Irit Avni. She's going to talk about us with IBD and fertility and pregnancy. She is a senior IBD specialist at Rabin Medical Center in Petah Tikva, Israel. For the past decade, she's been the co-director of the IBD Maternal Fetal Medicine Joint Clinic in the center. She's working with around 100 patients per year for preconception consulting and also the follow-up post-conceptional. She's also the lead, the PI investigation in the trial of IBD farm unit, and also the head of endoscopic capsule endoscopy service in the gastroenterology division. I hope she's going to give us a very, very interesting, a very important topic, because as we know, our little patients also, they get adults, and this type of knowledge, I think we have to know to give them a better advice. Thank you very much, Irit and Dr. Avni, for helping us with this and giving us a lecture with this topic.
Thank you. Just share my screen. I need you to allow me to share the screen.
Yeah, so let me just stop there. Do you think you can do it now?
Yes. Okay. So thank you for inviting me to talk to you about this important topic. And thank you for the introduction. The peak age of IBD diagnosis overlaps with the age of sexual maturity, establishment of intimate relationship, and family planning. And there are multiple clinical considerations to address, both during preconception and throughout pregnancy in patients with IBD. And in the next 45 minutes, I will cover key topics from contraception and fertility to management during pregnancy and medication, lactation and vaccination. And I will talk about these issues from the ECHO guidelines from 2022. And I'll base the discussion also on the much recently published global consensus statements from JCC last August. So let's start with contraception in patients with IBD. And I wanted to say that women with IBD seek guidance from us as gastroenterologists, and not just from their primary care providers. So it's important that we know about the topic of contraception. We have two main options to consider. We have oral contraceptives, and we have long-acting reversible contraceptives, including intrauterine devices and contraceptive implants. We also differentiate between combined estrogen and progesterone pills and progesterone-only formulations. With the oral contraceptives, absorption and adherence are key concerns. And for estrogen-containing options, we must consider the risk of venous thromboembolism and perhaps the risk of disease flare. The ECHO guidelines reassures us that combined oral contraceptives are effective in women with IBD, are not associated with increased risk of a flare, and are generally low risk. Nevertheless, we should consider the thrombotic risk of our patient. The new global consensus advocates for the use of long-acting reversible contraception over estrogen-containing contraceptives, as these are most effective. They eliminate human error, they avoid issues with absorption and interaction, and they reduce the risk of VTE that is associated with estrogen. Fertility in women with quiescent IBD and no previous pelvic surgery is reassuring. For ulcerative colitis, it is comparable to the general population, and in Crohn's disease, we see a slight reduction in fertility. And we can talk about several factors that contribute to reduced fertility in women with IBD. Voluntary childlessness is 3 times more common in women with IBD as compared to the general population, mostly in Crohn's disease. And to some extent, it is driven by misconceptions and lack of adequate information, and therefore it is potentially reversible with counseling. Pelvic surgery can also contribute to infertility. In ulcerative colitis patients and pouch surgery, there's a 3-fold increased risk of infertility, and minimal invasive surgery can lower this risk. For Crohn's disease, the impact of pelvic surgery is less clear, as was also shown in a Cochrane meta-analysis, but pelvic surgery does contribute to prolonged time to conception. Active IBD is no doubt a contributor to higher infertility rate. IBD patients also have lower ovarian reserve, as seen with reduced AMH levels. Active Crohn's disease and age over 30 are consistently associated with reduced levels of AMH. And delaying pregnancy further impacts fertility, especially in women with IBD. And therefore, early referral to infertility evaluation should be based on these factors, including pelvic surgery, age, and active IBD. We can reassure our patients that women with IBD may have comparable effectiveness of assisted reproductive technology when compared to women without IBD, as measured by live birth. And also, women with IBD who have undergone pelvic surgery have similar effectiveness of IVF when compared to women without IBD. As fertility preservation technologies become more accessible and widely known, an increasing number of women with IBD are starting to inquire about this option. And this topic was discussed in the recent global consensus, and it was decided that women with IBD may undergo egg retrieval without increased risk of a flare. However, whether women with IBD can continue all medications except methotrexate during the procedure remains uncertain, and there's a specific concern regarding the use of JAK inhibitors. IBD course during pregnancy depends on disease activity at conception. We can tell our patients that if they conceive while the disease is quiescent, the risk of a flare during pregnancy resembles the regular annual risk of about 20 to 30%. However, if our patient conceives when disease is active, she is most likely to suffer from a flare during her pregnancy. And this concept is also supported by this meta-analysis that was published over a decade ago. As you can see, active disease at conception is associated with a 2-fold increased risk of active disease during pregnancy, and this is shown for both ulcerative colitis and Crohn's disease. Patients with ulcerative colitis have a higher risk of relapse during pregnancy. In this ECHO-EPICOM study of 200 pregnant women with IBD, pregnant women with ulcerative colitis were more likely to relapse during both pregnancy and the postpartum period as compared to non-pregnant UC patients during the same time frame. And this high risk of exacerbation during pregnancy was not observed in pregnant women with Crohn's disease. Several explanations were proposed for this discrepancy. Perhaps the change from Th1 to Th2 immunity seen during pregnancy, perhaps due to smoking cessation, or to differences in the therapeutic approach between Crohn's and colitis during pregnancy. A more recent Danish study from Professor Mette Julsgaard's group also shows the connection between active disease during conception and risk of active disease during pregnancy. In this study, you can see that disease activity within 6 months of conception was associated with a 5-fold increased risk of active disease during pregnancy. And even more important, even if the disease was active within 6 months of conception, but remission was attained at the time of conception, this elevated risk was eliminated. They also showed that disease activity in previous pregnancy is associated with increased risk of activity in subsequent pregnancy, probably reflecting a more severe phenotype. And consistent with earlier findings, ulcerative colitis was again associated with an elevated risk of activity during pregnancy, while Crohn's disease was not. Patients with IBD experience more pregnancy-related complications compared to the non-IBD reference population, and this risk is significantly increased when IBD is active during conception and pregnancy. As you can see in this large French study comparing IBD pregnancies to a large cohort of control, you can see that stillbirth, preterm birth, low birth rate, and IBD-related hospitalizations were much more, the risk was much higher when disease was active during conception and during pregnancy. So to reduce the risk of pregnancy-related complications, the optimal time for conception is during disease remission. And we aim for at least 3 to 6 months of steroid-free remission prior to conception, ideally confirmed by objective markers and endoscopy. And in order to achieve this goal, we need to have proactive planning and to have an open discussion with our patients about family planning. And the optimal setting to do so is a structured preconception counseling. Preconception counseling is very important as many of our patients hold incorrect beliefs and lack sufficient knowledge about IBD treatment during pregnancy. Preconception counseling makes a difference. It is associated with healthier behavior and improved pregnancy outcomes. But still, in a survey of almost 800 patients, most did not receive counseling, and only about 10% received counseling from an IBD specialist. Preconception counseling is also a great valuable opportunity to address broader aspects of healthcare maintenance, including smoking and alcohol cessation, dysplasia surveillance, assessment of nutritional status and achievement of ideal weight, and vaccination review. It's also the optimal setting for an interdisciplinary consultation with our dietitian, with the obstetric specialists for women who have history of prior obstetrical complications, and to include our colorectal surgeon for patients with the perianal disease, with a pouch, or with an ostomy. This is the setting to initiate or optimize therapy to achieve remission prior to conception, to confirm remission, to discuss the need to avoid prohibited medications, and to decide on a medication plan for pregnancy. And in some patients who needed surgery even before discussing pregnancy, we sometimes refer them to surgery before planning pregnancy. So after we've discussed the aspects of preconception care, let's move on to discussing pregnancy management. Pregnancies in women with IBD should be considered as high risk for complications. But in many cases, because our patients are young and otherwise healthy, they are not recognized as high-risk patients, despite the link to adverse maternal and obstetrical outcomes, especially when the disease is active. The definition of high-risk pregnancy also differs globally. In some places, the pregnancy is cared for mostly by midwives. So regardless of the care setting, it's important that all healthcare providers would be educated about the risks and monitoring needs in pregnancies with IBD. During pregnancy, we should monitor for disease activity. The biomarkers that we usually use to assess disease activity change physiologically during pregnancy. So in a normal pregnancy, we can see leukocytosis, obviously anemia, elevated CRP, and slight decrease in albumin. Fecal calprotectin is not affected by pregnancy, and therefore it is a very good tool to assess disease activity during pregnancy. Intestinal ultrasound is being used more and more, even also in pregnancy. And we know that with experienced hands, we can visualize the terminal ileum in most patients, in over 90% of patients up to week 20. And in 2/3 of the patients, we can see the terminal ileum even up to week 26. And the colonic segments apart from the rectum can be visualized even further into the 3rd trimester. If we decide on an MRE, it should be done without gadolinium. And we usually use MRE for specific cases when we consider there's a significant complication. Sigmoidoscopy is a low-risk procedure, and we can use sigmoidoscopy throughout pregnancy. And colonoscopy is also performed when needed if we have a strong indication. For example, if we need to establish a diagnosis of Crohn's disease during pregnancy. And if we can, it's preferable to do the colonoscopy in the 2nd trimester. Gestational weight gain is an independent factor influencing pregnancy outcomes. Women with IBD are at increased risk of inadequate gestational weight gain. This is slightly more for Crohn's disease than for UC. And we can think of several reasons for this inadequate weight gain in patients with IBD, including extensive active inflammation, bowel resection, chronic diarrhea, obstructive symptoms, and also nutritional restrictions and avoidance. The American Piano Registry showed that inadequate gestational weight gain it was an independent risk factor for adverse outcomes, including preterm birth and intrauterine growth retardation. So it's important that during pregnancy, we monitor caloric intake, vitamin supplementation, and weight gain. Women with IBD may have an increased risk of preterm preeclampsia. And we know that low-dose aspirin may prevent preeclampsia in at-risk patients. The new global consensus guidelines recommend that pregnant women with IBD should take low-dose aspirin starting by week 12 to 16 of gestation to prevent preterm preeclampsia. And some recommend stopping at the week 36 to reduce the risk of bleeding during delivery. The use of IBD medications in pregnancy remains one of the most controversial areas in IBD care. It's very important that we understand that our patients are concerned, and providing reassurance is very important to maintain treatment adherence. And we can say that the general rule is that the medication that achieved remission before pregnancy is generally needed to maintain remission during pregnancy. And apart from methotrexate and small molecules, we can say that IBD medications are of low risk and can be initiated and continued during conception and pregnancy. If we look at what we used to call conventional therapy, There's no increased risk of congenital malformations or adverse pregnancy or fetal outcomes compared to the general population. So we can start or continue oral or topical mesalamine. We can use systemic and locally acting steroids, and we can continue thiopurine monotherapy. Initiating therapy with thiopurine is generally not recommended because we have a slow onset of action and the potential risk for adverse events. As for antibiotics, metronidazole and amoxicillin can be administered to pregnant women. For ciprofloxacin, there was some divergence in guidelines. In the ECHO guidelines from 2022, it was recommended to avoid ciprofloxacin in the first trimester. But recent data cited in the global consensus suggests that use of Cipro in the first trimester was not associated with increased risk of major malformations. And if we need these antibiotics, we can use it even in the first trimester. I wanted to emphasize that steroids, if needed to treat a flare, can be used during pregnancy, including during the first trimester, always in a wisely manner and never as maintenance treatment. We have reassuring data from a large Danish nationwide cohort study and from the American Piano Registry, showing that there's no increased risk of congenital malformations with use of corticosteroids during the first trimester, including orofacial clefts. The Piano Registry did show that exposure to corticosteroids was associated with maternal and pregnancy adverse outcomes, including preterm birth, low birth weight, and NICU admission. But I think that these findings may be confounded by underlying disease activity. Use of steroids during pregnancy in the Piano cohort was associated with a threefold increased risk for gestational diabetes. Regarding infant infections, exposure to corticosteroids was not associated with an increased risk of infection in the first 12 months of life, but a sub-analysis did show an increased risk of infection at 9 and 12 months of life if steroids were administered in the second or third trimesters. And also there was a large Taiwanese study that showed that exposure to steroids during pregnancy was associated with serious infections in children born at full term. We said that we can continue thiopurine use in pregnancy, but the FDA cautions us for a potential association between thiopurine use during pregnancy and an increased risk of intrahepatic cholestasis of pregnancy, and the proposed mechanism is metabolite shunting. Therefore, we should monitor liver enzymes in each trimester. It's preferable if we can measure thiopurine metabolite levels once during pregnancy, if it's available. And we can also split the thiopurine dose to reduce the risk. The concomitant use of allopurinol is not recommended. As I said, biologics are considered a flow risk and can be initiated or continued during pregnancy. It's very important that if a pregnant woman has a flare, she should be managed according to the guidelines for non-pregnant patients, including 5-SA, steroids, biologics, and cyclosporine. And here you can see from this large-scale meta-analysis that there was no increased risk of adverse pregnancy outcomes and congenital malformations for women who were exposed to a biologic throughout pregnancy. As you know, biologics are monoclonal antibodies, and due to their size, they do not cross the placenta in early pregnancy, hence the low risk for congenital malformations. But there's an active placental transfer that begins around week 14 through the Fc receptors. And 80% of this antibody transfer occurs in the third trimester. And during labor and after labor, the newborn has elevated levels of the drug in the blood. The degree of placental transfer varies significantly between the biologics, as reflected by the cord to maternal drug level ratio. We have the highest transfer for infliximab. Certolizumab does not have the Fc portion of the antibody, and therefore there's no transfer. For adalimumab and ustekinumab, the ratio is 1.3 and 1.6. And we have the lowest transfer for vedolizumab with a ratio of 0.5. Professor Uma Madhavan recently published some data regarding risankizumab, and she showed us from a few cases that the placental transfer is low for risankizumab with a ratio of 0.3. In the past decade, there was an ongoing discussion or debate regarding the use of biologics during the third trimester. The concern was that if we stop, we obviously risk a flare during the third trimester or postpartum period, and we may risk immunogenicity and loss of response when we reintroduce the drug. And on the other hand, if we continue, we know that we do not have long-term safety data, particularly beyond infancy. The current guidelines are united and very clear, and they support continuation of biologic therapy throughout pregnancy, understanding that the benefits of maintaining remission outweigh any potential risk of continued exposure. Regarding small molecules, currently JAK inhibitors and S1P receptor modulators should be avoided during conception and pregnancy, as they were found teratogenic in animal studies. We have very limited human data, mostly from clinical trials and post-marketing surveillance, and this little data did not show any clear signal for increased risk, but this is very limited data, very small sample size. There's a frequent rate of loss to follow-up, and we know that during a clinical trial, even if there was an exposure during conception, when the patient understands that she's pregnant, she stops the drug, or in some cases, even an abortion is decided. An interesting fact to notice is for animal studies with tofacitinib, there was no observed elevated risk of congenital malformations at doses matching those used in humans. For the other small molecules, even when used in those matching those in humans, there were congenital malformations and even fetal death. So currently, the recommendation is to stop the JAKs at least 4 weeks before conception, etrasimod at least 2 weeks, and ozanimod at least 3 months. But as you know, real-life scenarios are much more complex. And for patients in whom we do not have any alternative, after careful consideration and shared decision-making and proper documentation, we may decide to continue the JAK inhibitor or to initiate it later in pregnancy. And in the past UEGW conference, Professor Mette Julsgaard presented a very important study. She presented a cohort of 55 pregnancies exposed to JAK inhibitors from 15 countries. 90% of the patients had ulcerative colitis, and in 30%, concomitant corticosteroids were administered, and you can see that half of the cohort had active disease. Most patients received tofacitinib, and most patients received the JAK inhibitors, continued it throughout pregnancy. And reassuringly, there were no signals for maternal complications, including DVT, preeclampsia, hospitalization due to infection, and there were no adverse signals regarding pregnancy outcome, infant development, infection risk, vaccination exposure. So this is reassuring, but obviously we need much more data. Regarding delivery, multidisciplinary approach is important. The approach should be that the cesarean delivery should be based on obstetric indications. For patients with active perianal disease and for patients with a rectovaginal fistula, we do recommend a cesarean delivery. For patients with healed perianal fistula and for patients with a pouch, there's a tendency towards cesarean delivery, but it should be a case-by-case discussion. And after delivery, if our patient did withhold the biologic during the 3rd trimester, it's very important to resume the biologic after delivery, and we can resume the biologic after 24 hours of vaginal delivery and after 48 hours of a cesarean, obviously if there was no infection. Pregnant women with IBD have an increased risk of venous thromboembolism during the pregnancy and the postpartum period compared to women without IBD. So around labor, we should consider VTE prophylaxis during hospitalization and the postpartum, particularly for cesarean delivery. And all patients with IBD who were admitted due to a flare should receive VTE prophylaxis, and this is even more crucial if they are pregnant. As for breastfeeding, the drugs that are considered low risk during pregnancy are also considered low risk during breastfeeding, and they can be continued. Currently, it is recommended to avoid small molecules during breastfeeding. We have emerging data regarding the transfer of the small molecule through the breast milk for tofacitinib and upadacitinib. And we can see that the relative infant doses for tofa are 3.4%, for upa 2.7%, and this is considered relatively high as compared to other IBD drugs. And also the bioavailability from the gut is high. So there may be a transfer to the infant, and it is recommended to avoid breastfeeding with small molecules. Let's discuss vaccines in infants exposed to biologic in utero. Inactivated vaccines are recommended according to national guidelines. There's no adverse events. There's an adequate serologic response. As for live attenuated vaccines, concern has been raised regarding BCG vaccine due to 5 cases of death from disseminated BCG infection when the vaccine was administered to infants who were exposed to anti-TNF in utero. The ECHO guidelines from 3 years ago recommended that for vedolizumab and ustekinumab, live attenuated vaccines can be administered from 6 months of age. This is based on the drug clearance data. And for anti-TNF, it was recommended to avoid live attenuated vaccines for up to 12 months of age or until clearance is confirmed. In the past 3 years, we had a lot of data regarding the exposure of infants who were exposed to biologics in utero to the live attenuated rotavirus vaccine. So we have several retrospective studies and also prospective studies. And all of this data shows that there is no serious adverse reaction when the vaccine is administered to infants who were exposed to biologics, including anti-TNF, including during the third trimester. And the new global consensus embraced this reassuring data. And currently, the statement is that we can administer rotavirus vaccine to children who were exposed to biologics in utero. Regarding the BCG vaccine, the global statement is that it should be avoided in the first 6 months of life in children who were exposed to anti-TNF, so 6 months and not 12 months. We know that this vaccine is more vital in some parts of the world, but we also know that it is more dangerous to the biologic exposed infant. And the recommendation is to consider according to the regional risk. And the consensus understands that in some high-risk countries, when the BCG vaccine should be administered early in life, if we can measure doses, but in some cases or some places of the world, it is even legitimate to decide to stop the biologic in the third trimester. Regarding neonatal outcomes, as we said before, if the disease was active during pregnancy, there's an increased risk of low birth weight, SGA, preterm delivery, spontaneous abortion, neonatal ICU admissions and hospitalizations in the first year. There's no increased risk of early childhood malignancy and early childhood developmental delay. And in the last part of the talk, I wanted to discuss briefly the risk of IBD in the offspring. And I will touch shortly about genetics, antibiotics, and diet. As you know, if the parent has IBD, there's an elevated risk of IBD in the offspring. If the parent has Crohn's disease, the risk for the offspring is 8-fold increase. If the parent has ulcerative colitis, there's a 4-fold increase. All those studies discussed the increased risk of maternal transmission of susceptibility, but current studies show that there's an equivalent risk between parents. And as you know, if both parents have IBD, the estimated risk is higher, about 30%. What about the impact of prenatal antibiotics on the risk of IBD in the offspring? We do have epidemiological data that shows that prenatal antibiotics is associated with an increased risk of IBD in the offspring. A large Swedish population-based study showed an elevated risk of very early Crohn's disease with intrauterine antibiotic exposure. And the Danish population-based study showed that if the mother was exposed to 3 or more courses of antibiotics in pregnancy, there was an elevated risk of ulcerative colitis. So if we can limit the prescription of antibiotics during pregnancy, this might be helpful, but as you know, it's not always possible. Regarding Western diet and its associated risk for IBD in the offspring, we have data from animal models or animal studies. The large Norwegian mother and child cohort study showed that higher maternal diet diversity during pregnancy was associated with a lower risk of ulcerative colitis in the offspring. The large prospective longitudinal birth cohort study called Mommy IBD from Hong Kong showed that mothers with IBD had higher consumption of food additives as compared to non-IBD mothers. And this food additive intake was associated with a dysbiotic microbiome, and it was associated with higher fecal calprotectin levels in the gut of the infants. The MELODY study takes us several steps ahead. The MELODY study is an interventional trial that assesses the impact of IBD anti-inflammatory diet on the microbiome of the pregnant women and of the microbiome of the newborn. And this study will hopefully teach us a lot. And currently, the guidelines recommend for a balanced Mediterranean diet and to avoid ultra-processed foods, perhaps also to reduce the risk of IBD in the offspring. In summary, a healthy mother is a healthy baby. We should be clear on the impact of active disease during conception and pregnancy. We should treat active disease, and if needed, we should induce remission with a biologic and with corticosteroids. We continue the biologic during pregnancy. And as always, communication and multidisciplinary approach and shared decision-making can contribute to our success. Thank you.
Thank you very much, Dr. Avni. Very, very nice presentation, very practical, and also very useful with a lot of details, and very, very, very nice. Thank you very much. I enjoyed very much. I think we have some questions from our participants. I would like to answer or ask you if you're okay. Some ask you if in this study that you show us about the rotavirus vaccine, at what age did the children been exposed with the biological in the uterus receive the rotavirus vaccine, and if they in the study they also looked the time when was the last dose received, and if they also considered the doses.
So regarding the exposure, most of the exposure was throughout pregnancy, so including the third trimester. Regarding the timing of the rotavirus vaccination, it was as general according to the standard. And the third one, what was the last? The dosing.
Yeah.
Dosing, I must tell you that I didn't look at it specifically. It was, I suppose, the standard dose, but you need to look it up.
Yeah, thank you. Also, they ask us if during the pregnancy, if we can use the video capsule endoscopy also as a diagnostic test, or if it's also
in general, capsule endoscopy is not recommended. It's contraindicated during pregnancy. First, it was not used in the clinical studies when the capsule was developed. It was obviously not tested in pregnant women. And also, if we have a risk of retention, we do not want to be in this situation during pregnancy. So we do not use capsule endoscopy during pregnancy. We have other imaging studies.
Thank you. I wanted to ask you, because we know about pregnancy and fertility. We always talk about our primary knows about women, but in men, for example, some maybe couples that they are trying so much time, and maybe we also think because maybe it's the women, but sometimes maybe in IBD patients, male patients also could have some issues. Can you tell us a little bit something about that?
It's a very important point that you raised. It's very true. Regarding medications, sulfasalazine may lead to sperm dysmotility, or so it is recommended to stop the sulfasalazine or to switch it to regular 5-ASA. And there was regarding small molecules, we also do not have a lot of data, so it's a case-by-case discussion. If our patient is on a JAK or a small molecule, And this is the drug that got him to remission. We do not change it due to fertility or concerns. Regarding infertility, you're right. The can be problems associated with surgery, and we should be. It should be. We should refer patients to have a checkup and consider it.
Great, thank you. Let me see if somebody else has a question. I know, Marie, if you have someone.
Yes, I do have a few questions. What I would like to ask you is, like, in clinic, when you're counseling a couple, how do you usually counsel families with IBD with regards to the risk to their offspring? What is the advice that you usually give so that it's reassuring, but at the same time evidence-based?
I recommend to the obvious things like healthy diet, which is good for the whole family. I tell them that when their kids will grow up, they can't smoke. I advise for like conscious use of antibiotics, but sometimes parents give antibiotics by themselves, but so conscious use of antibiotics. And I try to to lower the concern regarding genetics. This is basically.
Okay. I think that's very helpful, because in our day-to-day practice, sometimes it's difficult to show the data where people can understand it. And now with the use of AI, sometimes we feel worried that probably the patients know more than us sometimes. So it's nice to have practical advice from you on how to approach such scenarios. Another question that sometimes comes up is vaccinations to the offspring. So if the mother is on biologics, some people are concerned about the use of live vaccinations on the offspring. Do you usually get involved with similar scenarios, or is it something that the pediatricians usually do?
No, our patients ask us about everything, related and unrelated, So we spoke about the rotavirus that is now okay. Regarding the vaccines for 1 year of age, the mumps and measles and rubella, the MMR, that is given at 12 months of age, the infants should receive the vaccine even if the mother is on a biologic.
Great. I also wanted to ask you, Dr. Avni, about the diet, because also what you said about the food additives maybe would be a very nice type of study to see if some type of intervention before the diet could help to see the type of the diet that they have, to see if they develop in the offspring the risk of IBD. I think it's the diet. It's important not just because of the grow or the development of the baby, maybe, but after that also the risk of developing also diseases. So it was also very interesting. Thank you. Let me see if anybody have also other questions. And do you have some other questions? I think
I would like to share an experience I had. So once I had a patient who was diagnosed with Crohn's disease. The mother was also an IBD patient, and the child herself had quite severe perianal disease. During the time that I was following this patient up, the mother got pregnant with a second child. So it was quite an interesting experience for me, because I had to deal with one child, but at the same time with a mother who was dealing with a second pregnancy. And I think one of the things that worried me a little bit is that she never had an endoscopy prior to her second pregnancy, and she was on just mesalazine. So I was very worried that she might develop a high-risk pregnancy. I'm sorry, my son has decided to join us during this conversation. Apologies. So I thought if I could have a biomarker that could help me, that would have been really useful in this scenario. But maybe just calprotectins I could use. Even intestinal ultrasounds are not yet used frequently in my country. I don't know what your experience is in this type of situation when the pregnancy is not planned. How do you go about it, trying to make sure that the mother and now the offspring stays safe?
Yeah, you're right. In many cases, we preach about preconception counseling, but in many cases, the mothers come when they are already pregnant and they did not have endoscopy for several years and no MRE and nothing. And now she's pregnant, and you need to decide if her symptoms are a flare or not. And calprotectin helps us to a certain extent. This is why I love ultrasound so much. So I recommend everyone who can to have this option. Otherwise, sometimes you need to like work with your clinical understanding. Sometimes I use a course of budesonide just to see how it goes. And during pregnancy, you need to take clinical judgments sometimes more and rely less on objective measures. It depends.
And one last question. And what
And
happens?
for ulcerative colitis, or obviously you can do like sigmoidoscopy is very like easy.
Yeah. What happens if you have a family that does not want treatment? Would then want to temporarily stop all treatment? What is usually your advice when those patients come to you?
If my patient wants to stop all treatment before pregnancy,
Because of the pregnancy.
it happens. I can only give her the best advice I can, but some patients decide to stop, and then I can only support them and follow up and intervene if something occurs.
Okay. And do you usually see them at
Yeah.
specific times of their pregnancy, for example, at 20 weeks and
We we invite the patients to the clinic once every trimester,
okay.
and I sit together with the maternal fetal medicine expert. We sit together in the same clinic, and if we see them once every trimester, if everything is fine. If there's a flare or consideration, obviously we see them as frequent as needed.
I think it's a beautiful opportunity we've had this evening to
Yes.
get your experience, because it's something I think most of us would like to experience in their own institutions, to have this type of collaboration and an MDT approach when it comes to pregnancy and IBD. Although we see children, I feel that we do have quite a few young people who are interested or maybe a bit shy in asking questions. And I think the information you gave us about the contraception as well, it was very useful from my end.
Mm-hmm. Yeah, I think it was very, very practical and very, very useful for everybody.
Thank you.
I think if it's okay for everybody, I think we can finish. Thank you very much, Dr. Avni, for this very, very great talk and help us to continue learning. I hope we can be in touch also for any other further question if the participants ask. And thank you very much again for joining us this evening.
Thank you for the invitation.
Good evening.
Bye-bye.
Bye, everybody.
Bye-bye.